My name is Claude Hemphill. I'm a neurointensivist at the University of California, San Francisco, and Chief of Neurology at Zuckerberg San Francisco General Hospital. I'm one of the authors of the Neurocritical Care On Call chapter for Intracerebral Hemorrhage, ICH, along with Torsten Steiner, Dennis Parker, Deepa Patel, Hope Moser, and Ann Alexandrov. The purpose of this webinar is to provide complementary material to the chapter on ICH. So what I'll do is talk a little bit about etiologies, evaluation of the patient with ICH, and some specific aspects of treatment. I'm going to call out some of the tables and figures in the actual Neurocritical Care On Call chapter, but I want to emphasize that we're not going to cover everything, and that chapter is more comprehensive. In fact, it might be a good idea for you to have that available for you to review concurrently with this webinar. I know I've got a copy right here, and periodically I'm going to look over and refer to that. So just so we're all on the same page, intracerebral hemorrhage, or ICH, occurs from spontaneous bleeding into the parenchyma of the brain. Some people have used other terms like intracranial hemorrhage or intraparenchymal hemorrhage, but we suggest not using those terms because they can apply more broadly to other conditions. And really what we're talking about is a very specific disease, subtype of stroke known as ICH, distinguished from subarachnoid hemorrhage, interventricular hemorrhage, traumatic intracranial hemorrhage, hemorrhagic transformation of arterial or venous infarcts. We're talking about primary non-traumatic ICH. And in fact, when you look at various guidelines, that's what they call it. So we're going to talk about ICH as due to arterial small and sometimes large vessel diseases. It can obviously occur in the context of many different etiologies, but about 60 to 70% of ICH is caused by chronic hypertension with spontaneous rupture of very small arterioles that are going into the deep parenchyma of the brain, penetrating arteries that come off of large vessels, lenticulostriate arteries, perforators off of the basilar artery into the cerebellum or the brainstem, perforators off the posterior cerebral arteries into the thalamus. So it's the sites of ICH, especially seen on imaging, can help us distinguish cause of ICH. The table that you see in front of you lists a number of different etiologies of intracerebral hemorrhage. As we mentioned, arterial small vessel disease is the most common, and acquired small vessel disease from hypertension is far and away the most common cause. And in fact, if we could pick one thing that we could do to prevent ICH, it would be to improve the primary and secondary treatment of hypertension. By secondary, I mean in a patient that's already had an ICH. Primary would be primary prevention. Vascular anomalies such as arteriovenous malformations, cerebral cavernous malformations, or angiomas as they're now often called, or even intracranial aneurysms, either saccular aneurysms in the usual locations in the circle of Willis vessels, or mycotic aneurysms that may be infectious and more distal, can lead to primary intracerebral hemorrhage. And then we do have a small group of hemostatic disorders that can be particularly devastating if that occurs. Different cancers, hemophilia, hematologic malignancies. Also, unfortunately, sympathomimetic substances of abuse such as cocaine and methamphetamine are also a cause. Coagulopathy is often listed as a cause of intracerebral hemorrhage, and while this can be true, most often it's a patient with another etiology, such as a hypertensive hemorrhage, who happens to be on anticoagulation for stroke prevention and atrial fibrillation, or for venous thromboembolism, either warfarin or now many of the direct oral anticoagulant medications such as direct thrombin inhibitors or anti-10A agents. So patients with ICH are often very sick. And patients with ICH tend to present with more prominent decreased level of consciousness in patients with ischemic stroke, but we all recognize that there really are no clinical rules that can tell us whether somebody has an ICH or an ischemic stroke when they present in the acute stroke setting. So imaging is key. And this slide demonstrates the typical locations for intracerebral hemorrhage. And so the typical locations for hypertension are, as we mentioned, in those deep penetrating arteries. So the basal ganglia, the thalamus, the cerebellum, the pons. When we see a lobar ICH, that can be due to hypertension, but that raises our suspicion of conditions like cerebral amyloid angiopathy or an underlying vascular malformation. So that initial CT imaging is really critical. What about the initial classification of patients with ICH? Well, one of the things that we want to be doing for all our acute stroke patients, and really it's desirable across neurocritical care, is to get a baseline severity assessment. And in some sense, you could say, well, I'm doing a neurologic examination on that patient. I'm getting a sense of their baseline severity. But there are a number of different classification scales that help us understand the baseline severity. Now, notice I said clinical grading scales or classification scales. I am going to really push us to avoid using these for the temptation for initial prognostic information. Many of these scales, whether it's the Glasgow-Coma scale in traumatic brain injury, the Hunt-Hess or World Federation of Neurological Surgeons scale in subarachnoid hemorrhage, the NIH stroke scale in ischemic stroke, or the ICH score in ICH, really, the worse the score, the lower the likelihood the patient has a long-term favorable functional outcome. But we want to use these for baseline severity assessment, not to try to get some sense of accurate ultra-early prognostication. The chapter talks about the self-fulfilling prophecy. There are other articles on this. It's not going to be a big focus of this webinar, just to say, we're going to do a baseline severity scale. And now in front of you, the table demonstrates the ICH score. The reason we put the ICH score up there is it's the most commonly used and validated ICH clinical grading scale. That doesn't necessarily mean it's the best in terms of precisely giving an accurate assessment. But notice it has baseline parameters related to the clinical condition of the patient or their demographics and the imaging findings. So what you do is you assess the Glasgow-Coma score. You measure the ICH hematoma volume, which we'll get to in a moment. Check and see, is there interventricular hemorrhage? Is it an infratentorial ICH origin? And are they very elderly? You add up the points, and this gives a sense of how severely affected the patient is. And the purpose of this is to help risk stratify and to have good communication across providers. There are other scales out there, the Funk score, the Max ICH score, various modifications of the ICH score. And I'm going to leave it up to you as to which one you use. But please use a baseline severity scale in order to standardize the communication across providers. How do you calculate hematoma volume? This is something everybody ought to be able to do. And it's something that you actually learned in high school geometry, probably back when you were saying, like my teenage daughter just did a few days ago, I don't know why I'm learning this. How am I ever going to use this in the future? So then I showed her the formula for the volume of a spheroid, 4/3 pi r cubed, and we can reduce that down to the ABC over 2 way of calculating hematoma volume. So take the CT scan slice, and usually it's CT as opposed to MRI. That's the easiest test to do in acutely ill patients, as many of our ICH patients are. And take this axial slice that really eyeballs as the largest cross-sectional area. A is your longest diameter. B is the longest diameter perpendicular to A. And C is the number of slices that you see hemorrhage on times the slice thickness. Now, If you didn't have some offset, remember you'd be identifying the volume of a cube. So what you need to do is, if the slice that you're looking at has less than 25% of the reference slice, just throw it out. If it's 25 to 75%, once again by eyeball, then count it as half a slice, and it's 75% or greater, count it as a whole slice. So, an example would be, and from the chapter, we've got a patient who has A as 5 centimeters, B is 3 centimeters, and the hemorrhage is seen on 9 half-centimeter slices. 7 of them are greater than 75%, and 2 of them were in that middle range. So that gives you ABC, 5 times 3 times 4 over 2, and that's 30 cc's. So being able to do that reliably, it really helps with communication. It helps us to follow our patients, and it also gives us a good sense of a way to, it's part of calculating the ICH score. Okay. One other imaging finding that's now often done is we're used to giving contrast to patients for a ischemic stroke evaluation, looking for large vessel occlusions and potential endovascular treatment. But if we give contrast to patients who have ICH, the way this started out is looking for an underlying arteriovenous malformation, looking for an underlying tumor, perhaps. But what we realize is there's something called the spot sign. And the spot sign represents contrast extravasation into the hemorrhage. And you can actually see this on the CT angiogram. You can see it on the CT perfusion study if you do one. We tend to actually just do a post-con. We often will be doing the CTA and CT perfusion. But we always try to do a post-con because that's the last image that we would see with contrast enhancement. And the image in front of you demonstrates a CT scan with a spot sign. And this is a predictor of the likelihood that the hematoma is going to get bigger. Patients with spot signs also tend to do worse, presumably from hematoma expansion. However, identifying a specific targeted treatment in spot sign positive patients has remained elusive to now. So we've got our patient with an ICH. We've identified the likely etiology, perhaps as hypertension. We've done their hematoma volume. We've done their ICH score. We may have even done a contrast CT scan and found that there's no spot sign, let's say. What are we going to do in terms of treatment? Well, there are many different aspects of treatment, and some of these range from management of intracranial pressure, deep venous thromboprophylaxis, the question of seizure, anticonvulsant prophylaxis, continuous EEG monitoring, interventricular thrombolytics, and so forth. These are covered in the chapter in more detail, but I want to hit 3 highlights that are also a big part of the emergency neurological life support, ENLS, a module for intracerebral hemorrhage. And these 3 things that we really ought to ask the question about in every patient with ICH who comes in is blood pressure, coagulopathy, and whether surgery should be undertaken. So those are our 3 things that we're going to ask in every single patient. Why are those the 3 biggies? Well, first of all, hypertension is the most common cause, but even in a patient without chronic hypertension as the cause, most patients with ICH come in hypertensive. And it's been a very reasonable question to say, can we and should we actively, aggressively lower the blood pressure in order to decrease hematoma expansion, in order to decrease edema? So several randomized trials, and now 2 large randomized trials, INTERACT-2 and ATTACT-2, have been done looking at 2 different aggressive blood pressure lowering thresholds, to 140 systolic or 180 systolic. And taken in total, and some people may argue this a little bit, but taken in total, they haven't really suggested a major difference between these 2 blood pressure thresholds. But they brought out a number of really interesting issues. One, the aggressive blood pressure lowering arm, at least in the ATAC2 study, uh, tended to have more renal dysfunction, probably as a result of the aggressive blood pressure lowering. That's what we wonder. Um, and um, But what neither of these particular, and the other is blood pressure variability turns out to be a problem. So allowing big swings of blood pressure up and down seem to be associated with worsened outcome. So maybe it doesn't matter 140 versus 180. We've chosen 160 as our systolic blood pressure target now uh, at ZSFG. Um, but what neither of these studies have done, and what we don't have information on, is whether aggressive blood pressure lowering versus just let it ride high, let it ride 220, 240, whether that makes a difference. So I think we could debate whether there's actually equipoise enough to do a trial of lower the blood pressure to at least 180 versus who cares, let it ride. However, I think now the standard approach is going to be to lower it to at least 180, have an institutional protocol, and do this aggressively. The second issue is coagulopathy. And if a patient comes in on warfarin, or if they come in on one of the newer anticoagulant medications such as dabigatran, rivaroxaban, apixaban, they're at higher risk of ongoing continued bleeding and worsened outcome. So we're recommending reversal of those patients aggressively. The INCH trial looked at prothrombin complex concentrates versus fresh frozen plasma in the early reversal of warfarin-associated oral anticoagulant-related intracerebral hemorrhage. The study was stopped early, and it was a relatively small number of subjects. But it was actually stopped early because the regulatory bodies governing the study said you've already got a signal of favorable outcome based on decreased hematoma expansion and a strong trend towards a mortality benefit. I've heard Torsten Steiner, who's the PI, say he really wanted to continue the trial longer, and so did their data safety monitoring board, because they really wanted to assess whether there's a functional outcome benefit to this. But the data looks pretty good for PCCs over FFP, and so we're recommending those. What do you do about the patients on these other direct oral anticoagulant agents? Well, there's no data to show that reversal improves outcome, but it intuitively makes sense. And patients on dabigatran should receive idarucizumab, which is a directed monoclonal antibody. And there has not been an available agent for the anti-10A medications, but a medication called andexanet has just been approved by the FDA. It's not yet available in our hospital, and I'm not sure of the pricing information on this, but whether that becomes an agent that gets into clinical use broadly remains to be seen, and maybe something that's an early update for the Neurocritical Care On Call ICH chapter. Finally, the question of surgery. Well, this could take a long time to talk about, or it could be a very short time. The short answer is, as of right now, there are no randomized trials that have conclusively shown that surgery is of benefit. The problem is, there are no randomized trials that have conclusively shown that surgery is not of benefit. There might be some folks out there that argue with me, but I really don't think that the data is compelling either way. Now, the current American Heart Association intracerebral hemorrhage guidelines recommend surgery for patients with cerebellar intracerebral hemorrhage who are deteriorating or have mass effect, or it's greater than 3 centimeters with decreased level of consciousness. This is still a reasonable approach, even though there haven't been randomized trials. And I think we've all had patients where this has been life-saving if we do it quickly and definitively. But what about supratentorial ICH? Well, the STITCH and the STITCH 2 large clinical trials did not show a benefit of early surgery. One of the challenges, though, is both of these clinical trials allowed so-called salvage therapy. If they felt that a patient needed surgery, but they were initially randomized to the non-surgical group, as happened in about 25% in the original STITCH trial, and about 20% in the Stitch 2 lobar ICH trial, then uh, I think that muddies our ability to say definitively whether surgery makes a difference or not. There's an interest now in minimally invasive surgery, and this may take the form of stereotactic removal of a hematoma or placement of a ventricular catheter in a hematoma and installation of thrombolytics. Clinical trials are ongoing. And I think that's going to be very important information as we decide how we can properly treat our patients with ICH aggressively. I do just want to finish by mentioning that ICH has been a challenging disease to treat, and unfortunately, it's been one where there's been a lot of variability in care, and nihilism among some providers has led to limiting care on patients. Read the chapter more and other references to hear more about the self-fulfilling prophecy and so forth. But suffice it to say that guideline concordant care and aggressive care, even in the absence of a clear magic bullet, if you will, showing major benefits of a particular intervention, still make a difference. And I think we owe it to our patients to treat patients with ICH aggressively, to give them a chance, and to then incorporate new data as it comes along. Thank you very much, and enjoy Neurocritical Care on Call.